more respiratory problems. This is looking at just a different part of the respiratory system, though. So disorders of the respiratory system. So in this section, we're going to start with just an overview, and then we're going to look at respiratory tract infections. So this is your flu, cold. What else? What's it called? Tuberculosis and mycoplasma infections. Yeah. I don't know. We'll get to it. And then the rest. So respiratory tract infections. Then we're going to talk briefly about lung cancers, talking about the small cell lung cancers and non-small cell lung cancers. You think they just call it large cell, but whatever. And then I think what we'll do to make it a little bit simpler for y'all is just not talk about respiratory disorders in children. But the slide today if y'all want to go exploring. And you can ask any questions if you did read that. But we'll go ahead and eliminate those from the test at least. Respiratory system, right? I got all this stuff. Have y'all, hopefully y'all talked about it extensively in physiology. You'll talk about respiration a lot. So you got the this whole just tract that leads to your ventilation of the lungs, and then the alveoli for gas exchange. We talked about the pleura last lecture, and then you have, of course, blood flow through this whole system to pick up all the oxygen. So make sure you are well acquainted with that. And that's just a review of all that too. Again, you don't need to know necessarily be able to label this picture or anything, but just know, generally speaking, how air goes through your lungs and gets picked up by your vasculature. So one important thing is that, we talked about this last lecture where you need proper airflow and proper blood flow. But another thing is that you also have this barrier in between the alveoli and the blood. If anything's blocking that right there as well, that's also going to obviously impede your gas exchange. So anything that disrupts the barrier between the blood vessel and the alveoli will lead to impairment. All right, so the first thing we're going to talk about, the first infection we're going to talk about is the common cold. The most common cause of colds are rhinoviruses. We'll just leave that there, full stop, I guess. Rhinoviruses are really interesting. They're really small RNA viruses, but we can just leave that there. And but there's also other things that cause colds, like RSV, respiratory syncytial virus, and parainfluenza viruses, and even some coronaviruses. But that's not to be confused with what SARS-CoV-2 is. Like those are the SARS-CoV-1, SARS-CoV-2, MERS. Those are all not common cold viruses. So there's a whole bunch of coronaviruses that cause common colds as well. But again, the most prominent is these rhinoviruses. Rhino meaning nose, so it's a virus that infects the nose, or it doesn't really infect the nose, but they thought when it was discovered it would infect the nose. So again, most of us know what a common cold is, but you have a sore, scratchy throat, rhinorrhea, nasal congestion, sneezing, and coughing, right? Transmission can occur by hands, fingers, contaminated surfaces. The virus can survive for a little bit of time on surfaces, so that's why people disinfect things. And it's different for each, whatever the virus is, it's different. There was a whole whenever COVID started, there was a whole debate in the scientific community about how long it persists on surfaces while still being infectious, and how susceptible it is to different agents and stuff like that. And there's all these papers that were released for that. So similar stuff has been done, obviously, with all the common cold. Yep. Yeah, well, yeah, that's because you're directly going into the bloodstream, right? And so it's like really bad stuff can if that stuff gets in, yeah, you need to have a super sanitary work practices and workspaces. Um, and so treatment, these viruses mostly are self-limiting, which means that they grow aggressively at first, but they eventually reach a spot where the immune system um, controls it, and the virus just like it replicates so aggressively that it like will get into a cell, replicate really quickly, pop out, but then it'll meet the immune system. It doesn't like persist in cells like a herpes virus might, you know. So they're self-limiting disease. So typically people just say, go get some bed rest, drink lots of fluid, and you can get better. And then obviously antibiotics aren't going to do much. The only thing about antibiotics is that some viruses are accompanied with secondary bacterial infections because the virus comes in and weakens whatever the spot is, so bacteria can come in and replicate in that. So some people prescribe antibiotics with viral infections to prevent those secondary bacterial infections, but with the rise of antibiotic resistance, that's being called into question, and doctors are being told kind of not to do that, but then they're also being told to do that because of the secondary bacterial infection. So it's just I don't know, it's a clusterfuck, I guess. But I think as a whole, antibiotics are not recommended for viral infections, though. Full stop. There's also rhinosinusitis. This isn't rhinitis insofar as it's not the nose that's being inflamed, but it's all the sinuses around the nose that are being inflamed. So of the nasal passages, sinusitis inflammation of the paranasal sinuses, right? And this is mostly because of the obstruction of the sinuses. Sinuses drain and from the buildup of fluid, especially in the mornings. And so if they can't drain very well, you can get some inflammation. The acute's 5 days to 4 weeks, and it's also often caused by viral. If it's acute, viruses have significantly faster growth curves than bacteria, because you have to replicate less stuff. Viruses are like very, very small, even compared to a bacteria. The viruses are like big. I know, like HCMV and these herpes viruses that I study, they're like I think they're like 100 nanometers across, while bacteria are 2 microns across. So that's 2,000 nanometers across, so in diameter. So they're like significantly smaller than bacteria. And the eukaryotic cells, I think they're like 10 micrometers, and then there's eukaryotic cells vary a good bit, but
I know there's a big eukaryotic cell. I just took microbiology last semester.
Oh, okay. Yeah, eukaryotic cells are significantly bigger than bacteria, though, regardless. I just forget the actual numbers. Anyway, acute, but because they're so small, they replicate very easily, and they kind of come and go very quickly, especially with colds. While chronic is more bacterial, which can persist a little bit farther, and they have developed these nasal polyps as well. And then there's a whole bunch of mucociliary dysfunction, mucostasis, hypoxia, and microbial product release. Right, you are infectious with these things, and so you can go and infect people by sneezing and stuff like that. So with acute, there's going to be facial pain, headaches, purulent nasal drainage, pain with bending, and often difficult to distinguish from common cold and allergies, while chronic is only symptoms, maybe nasal obstruction. A sense of fullness in the ears. There's like a tube that connects the ears to the nose, and so you can feel some nasal inflammation in your ears.
I have a question.
Go ahead.
What is the surgery that's done on your sinuses? My cousin just got it, and he told me they put a balloon up there.
Rhinoplasty is like
That's
plastic
nose
surgery.
job?
That's not,
Yeah.
yeah, it's just a nose job. I know what you're talking about. I don't know what it's called. Um, but yeah, there's a way that you can expand your sinuses and drain them.
Yeah, because he had really bad region up there.
Mm-hmm.
He just got it done on Friday. And I was like, maybe I can get that done.
Well, yeah, look into it and report back. Let us know if you're going to get it done. Apparently, we're a class that shares a whole bunch of personal stuff.
Oh my god.
The which isn't a bad thing. Okay, so rhinosinusitis is where are we at? Well, share away. We're all ears right now. We don't have any acute facial. We don't have any chronic obstructions here.
I'm screaming.
All right. So there's also so treatment is depending on whatever's causing it, right? So if it's viral, it's self-limiting. If it's bacterial, you can take antibiotics. If there's nasal polyps, this may require some surgeries to remove them, and symptom management, intranasal corticosteroids, decongestants. These are your cold medicines that, and then obviously you want to get like lots of rest and lots of fluids just for normal stuff. With influenza, there are, so this is the flu, right? There are multiple different types of flus. Type A is where you infect a variety of species, which can cause either pandemics or epidemics. You know the difference between pandemic and epidemics?
Pandemic. For the whole world.
Yeah.
Epidemic is.
Yeah. Yes. So pan means all, right? That's how you can remember it. So epidemics, yeah, are just more regional. So this type A influenza has multiple. Okay. Type A can cause pandemics or epidemics, while type B is mostly just a lot of localized places. Wait, what? Yeah, and it's very possible. It's very common for a lot of people to do that. Yeah, it's just one type will knock you out, right?
Epidemic and pandemic was kicking everybody ass for COVID. Literally, everyone was saying epidemic. No, it's a pandemic.
Well, it started off as an epidemic and then it transitioned to a pandemic. Yeah, there's some really persnickety people that like to distinguish between the two, and they'll say like, oh well, Madagascar didn't have any COVID, and it's like, oh, it's not a pandemic. It's kind of bull. Yeah, New Zealand had some of the best border control in the world. Yeah, whatever. But so what flus are, they're characterized by these hemagglutinin and neuraminidase expressions. So you might hear H1N1. What that's referring to is the subtypes of those. These are both. I think I got a picture of it. These are both like these are these glycoproteins on the surface. Hemagglutinin is what actually binds to cells to allow them to enter, and neuraminidase is something I kind of study a little bit, kind of. What it allows is that these hemagglutinin will bind to a molecule called a sialic acid for viral release, and neuraminidase will come in, and the problem is that the flu uses that sialic acid to enter, but then when it's leaving the cell, there's still sialic acids on the surface of cells. And so what it has to do is for it to actually release from the cell into the environment, it has to cleave off that sialic acid with this neuraminidase enzyme. And that's going to be important for later. But there's this whole antigenic drift versus antigenic shift. So what happens is that your immune system recognizes the antigens that are on hemagglutinin and neuraminidase mostly, which are the two major glycoproteins on the viral surface of influenza. And they So influenza, because it's recognized by the immune system, this is just natural selection at its finest. What it'll do is it'll either have antigenic drift or antigenic shift. Antigenic drift is where you have these minor changes in the amino acid composition of HA and NA, and it just generates new subtypes, right? While with antigenic shift, this is where they're replaced with this is where like there's gene shifting. So this is people that actually get infected by different subtypes, right? And so because you're infected with two different viruses at the same time, part of the genetics of one virus, because two viruses that are different will infect the same cell, and part of the genetics of one virus will shift to the other, and they'll like exchange genetic material, and so you get these antigenic shifts, and that's what, because there's such major shifts, and a lot of times it even happens with like bird. You've heard of bird flu, like these antigenic shifts and drifts can happen in birds, to where they can become pathogenic to humans after they do this antigenic shift. So there's a lot of really cool research on flu because flu is such a consistent problem. But the big so yeah, that's just some interesting stuff. The transmission is through droplet inhalation, where you have a cough or a sneeze that we the flu virus itself is actually trapped in a droplet, which was big during COVID times. Is the hell? Oh, we've been on that slide for a while. Yeah. It's big on with COVID because it was contained in a droplet. It can't go through masks, right? Because of the weaves of mask. But if that contrasts to like if they're just not contained in droplets and they're aerosolized, which can go through things easily. So that kind of shows the efficacy of how masks work. And if you remember when we all wore masks, the flu rates just plummeted with regard to people getting sick. It's like every single year, I can try to look it up, the flu rates over time. Yeah, so this is a good graph. I don't know how I can whatever. So you can see here that right, every single year we have like a pop up of flu, pop up of flu, pop up of flu. But in 2020 we were all wearing masks and there were just no flu there, right? And there's barely any flu. And then 22 came back, and then these few cases just came back, and then it came back with a vengeance in 2020. What is that? I can't read these numbers. I guess that was 2020. So that's, yeah, 2022. It came in 2023. That was like a back to normal, no one wearing masks stuff.
I think I have the flu.
Right now?
No.
Oh, okay.
In December.
Well, that sucks. I've had the flu twice, and it sucks. Yeah. Yeah. So the big thing here is that we have clinical manifestations. Right, viral pneumonia is a big one. These are flu-like symptoms. Is the big. It's like a thing people say. With the flu, you have a very strong interferon response, and so these flu-like symptoms that are associated with all these other diseases, what they're just referring to is that it's just you have a severe amount of interferon released, and so interferon causes all those canonical stuff you hear: abrupt onset fever, chills, malaise, muscle aching, headache, watery nasal drainage, non-productive cough, sore throat. There's also viral pneumonia, rapid progression of fever, cyanosis, hypotension, and then this is the secondary bacterial infections that we talked about with colds. A bigger problem with flu. So this is where you just have bacteria. So a lot of people, even like people can prescribe antivirals, and that is, and we'll talk about. Have y'all talked about the antivirals? Or sorry, flu medications in pharmacology? I don't know if I. Yeah, so the way flu medication works is that neuraminidase that allows for release. Y'all heard of Tamiflu? Yeah. So that neuraminidase enzyme that cleaves off that salic acid for the viral release and spread of influenza. If you take Tamiflu, what that does is it inhibits the neuraminidase enzyme. So what'll happen is any viruses can get into cells and cause a little bit of pathology, but then they can't release and it spread. So you still have the flu, but then it doesn't like get worse. So it kind of just locks it in place. And then eventually, because you're locking that flu on the outside of cells, your immune system can recognize it and then get rid of it. So it's a really smart drug, Tamiflu is. But that's how that's an antiviral, right? So when we refer to early detection, you can treat with antivirals. You want to do it early because you're locking in the small amount of flu that's on the surface of cells. If it's too late, then it's yeah, that's just unfortunate. There might be something going on there. Yeah, so vaccinations, that's the big thing you want to do. There's a whole bunch of drama in politics and vaccination at this point, which is probably a shame. And there's people it's a whole bunch of old people that are running the vaccination office, and they're pretty hard-headed with regard to what they're doing is the way they want to do it. And so it's not as progressive as you might want it to be insofar as yeah, a lot of times we have a lot of ways that we can improve our flu vaccines every single year, and then we just keep on doing the same thing. It's kind of frustrating. Yeah, you have problems of if you just miss the strain and the subtype of flu, then a whole bunch of people get sick, and that's why we had these bad influenza years like we had in 2023. But regardless, sometimes I will say flu vaccines are very good for controlling elderly populations and pathology among the elderly. Contains protection against 3 to 4 currently circulating strains. So this is updated by the CDC, and then the Europe jumps on board for whatever the CDC does typically, and yeah, it's a good way of controlling stuff, of controlling influenza spread. We also have pneumonia. So this is infection of this area. It's not the alveoli, but it's kind of underneath that. It's the parenchymal structures of the lungs. But it also can be the bronchioles and the alveoli. Multiple causes. There's multiple causal agents that cause pneumonia. And we'll talk about Mycobacterium tuberculosis as one of those in the next slide. But there's multiple things that cause pneumonia. The setting, it's classified in different ways based off of the setting, whether it's a nosocomial or community acquired. Nosocomial just means hospital acquired. You all heard that term before? Nosocomial. Yeah. Those are a problem because it's like
it's right
there. Yeah. Those are a problem because like diseases can get worse. Stuff like that genetic exchange, like hospitals are a hotbed for flu, for example. So there can be, you can like go in for the flu and then get infected with the second flu, and then there's this exchange, and then you get a worse version, and then it spreads among all the hospital workers. And so hospitals are like a hotbed for disease, which y'all should know about. I mean, I work at the building, but I don't really ever go into the hospital unless I need to go to the calf. Yeah. So
UTIs are like the most common infection in hospitals.
What is?
UTIs.
Maybe. I thought it was respiratory problems, but you might be right. I don't know.
UTIs are like a big problem.
Also a problem. Oh, maybe so. Yeah. So they are also classified based off of if they're typical or atypical. I thought when I originally heard the COVID diagnosis, I thought it was, they said it was an atypical pneumonia. And I thought that was just like, oh, it's a weird looking pneumonia or whatever. It's not what atypical means. So typical pneumonia is bacteria that replicate in this area, right? So this would be typical this would be typical pneumonia where you just have bacteria replicating in here, and there's going to be some fluids being released, but it's like they're blocking the gas exchange here, but it's just bacteria growing in the alveolar space. Atypical is where you have viruses replicate, and then they just either release fluids into this area, or they destroy the alveolar to where you don't have good gas exchange, and they invade the alveolar septum. So so when they said atypical pneumonia with COVID, what they're saying is just viral caused pneumonia, pretty much, right? And then it's also about the distribution of the infection. Is it only contained within one lobe, or is it all over the place? Is it patchy, or is it full? There's just different descriptions of what pneumonia is. So tuberculosis is one of the things that causes pneumonia. I don't know where it says that. But so tuberculosis is really bad. It's a very weird bacteria. Did you talk about it in this microbiology class you took?
You said what?
Mycobacterium.
I don't remember.
So mycobacterium are weird because they have mycolic acids on the surface of this thing, which is a very waxy substance. And so because of that, they're very hard to remove by the immune system. So it's a very deadly disease. In 2021, there's the 13th cause of death, top 10 in the lower middle income countries, second leading infectious killer after COVID, but above HIV. Which HIV? I don't know. Well, I got a PhD in micro, but a couple times. Wait, what? Oh, yeah, that's like a regular practice that I do consistently. Yeah.
So you still, since you're as a professor here, you still have to do like research and stuff, right?
Well, I'm not a professor. I'm just like a part-time employee. You're shocked by that? What? Yeah, for sure. But no, so my main job is research. Yeah. But the reason why we do that is that what we do is we grow the HCMV genome in bacteria. So we grow like bacteria all the time on agar plates and stuff like that. But it's all in E. coli. It's not anything like this, obviously. And it's non-pathogenic. All the pathogenicity islands have been removed and blah, blah, blah. But
so what's the fun in it?
The HCMV is still pathogenic. So, there's that. But because HCMV is, we're not getting into that. Yeah. We're talking about lung diseases right now. This rod-shaped. So the bacteria itself is a rod-shaped aerobic bacterium that is resistant to destruction, and it's resistant to destruction because of this protective waxy capsule made of mycolic acids. So it's a really, really devastating disease. And then it transmits through droplet inhalation, just like the flu, and coughing and sneezing and talking. So again, this is another thing that went down during COVID times, because a lot of people were wearing masks. There's primary tuberculosis, and this is where you have literally just the inhaled bacteria are deposited into the alveoli, and then they start to grow. What will happen, though, is that alveolar macrophages ingest them but cannot kill them because of this protective waxy capsule. And then you can have a cell-mediated hypersensitivity. And so this is why your immune system remembers this has memory about mycoplasma, the mycobacterium, and so what you can do is you can put a little bit of that mycobacterium antigen underneath your skin, and that's what these tuberculosis skin tests are. So if you have a positive skin test, what that'll tell you is have you had Is your immune system reacting to it? Have you had tuberculosis or this infection before? What will also happen is that because these, so your macrophages won't kill it, but your macrophages will still sense it, recruit in other immunoprotective cell types to the area, and what will happen is that you can develop this like immune system wall around wherever that bacteria is, and that's what the granuloma is. It's immune response that walls off the organisms that can't be eliminated. And then there's this gone, which is a granuloma within a lymph node. I don't have a picture of that, but this is a picture of the granuloma right there. You can see on this white part. You can see it that's formed around it. So they can get quite large, and they can, depending on how much bacteria is there. And then there can be this latent TB infection, but those typically are not contagious. And this is what this is the gone right here is the combination of the primary lung lesions and lymph node granuloma. So it's the lymph node granuloma is this gone word. It contains macrophage T cells and inactive TB bacteria. Visible by X-ray, right? So that's the way that you can also see these granulomas in the lungs. So with primary TB, usually you have isolated in gone foci, and if the immune response is inadequate, bacteria multiply in the lung. So if they're in the gone foci, they're not contagious, the bacteria are inactive, and they're kind of just walled off, right? But if the immune response is inadequate, the bacteria multiply in the lungs, they progressively go to primary TB, and you'll start to show signs of pneumonia, bacteria in the septum, and in droplets, and that's when it's very contagious, right? And then bacteria may erode the blood vessels and spread through the body, and you can get miliary DB. And it can spread to other tissues. So this primary TB is kind of what people are mostly concerned about. You also have secondary tuberculosis, where you have reinfection or reactivation of the TB after it comes back from latency. Latency being like, right, where it's this inactive form. We talked about with herpes viruses, and other viruses we talked about with latency, but bacteria can also go into latency as well. They have immediate cell-mediated responses, which wall off the infection, and enhanced tissue damage leads to cavitation and increased dissemination. So again, this is your immune system doing the damage here, rather than the actual bacteria itself. Clinical manifestations are low-grade fever, night sweats, easily fatigable, anorexia, and weight loss. This consumption word, which is all around microbiology as well, and it can be fatal if left untreated. So you also have fungal infections. There's different yeast and mold that have infectious spores. A lot of times it's like this cell-mediated hypersensitivity. Your body's pretty good at dealing with fungal and molds, but they can creep into your lungs pretty easily, and so it's just the presence of these replicating yeasts in the lungs are what you're going to see diagnostically. Most are asymptomatic, but can be severe fatally at heavy exposure or immunocompromised individuals. This is a major problem during the HIV era in the 1980s, where, and it's still a problem today, where people get HIV. It can progress to where you're killing off those CD4 positive T cells we talked about, and then your immune system is very good at dealing with these yeasts and molds, but when your immune system's destroyed by HIV and our other things, like if you get transplant recipients have dampened immune systems, these yeasts can actually get in pretty well and can cause problems. So it's not a non-issue, but usually if you're healthy, these are more they're either asymptomatic or they're It's just not a problem. So lung cancers. And this is where we have all right, so a lot of what we talked about before with cancers are going to be applicable to lung cancers, right? So it's not going to be too shocking. So the major risk factor is cigarette smoking. Obviously, most people have probably heard about this point, and that's linked to about 80 to 90% of lung cancers. The weird thing is, and I guess what I want to emphasize here is that 80-90% are associated with smoking. That means 10 to 20% are non-smokers, right? So if you're part of those 10 to 20%, your patients can be like shocked by the fact they have lung cancer when they're like, I don't smoke though. It's like, why do I have lung cancer? And there's other things that cause lung cancer than just smoking. There are asbestos, industrial hazards like asbestos, dust containing arsenic, chromium, nickel, vinyl chloride. So if like the stuff's in your house or in your workplace and you didn't know about it because of building regulations from the 1930s, it's
Wasn't that like a big thing after 9/11? The lung cancer thing?
Maybe. I haven't heard of it, but
I know, like,
that doesn't sound shocking. I wouldn't be shocked.
People, because of all the
yeah. You would just release it all into the environment. Yeah, totally believable. I just haven't heard of that before. But we can look into it. Yeah, lung cancers are very problematic, obviously. They're aggressive, locally invasive, and widely metastatic. So they very much can move easily because of all that blood flow, right? That it's like there's so many. I think did I have a picture of the blood? It's kind of like this one, right? If you have like that level of vascularization around every single alveoli, it's like there's just so many blood vessels around your brain. So it's not that shocking that it's widely metastatic. Now there are so lung cancer often diagnosed late, thus prognosis is generally poor with a low 5-year survival rate. And there's two different types. There's this small cell lung cancer and non-small cell lung cancer. And we'll talk about these right now. So they're classified based off of their histology or histopathology. So what you can see here is obviously there's very small cells, generally speaking. There's not really reference cells, but what the problem here is that these are neurosecretory granules, and so they secrete a whole bunch of stuff, and we'll talk about them later. But they may arise from neuroendocrine cells from the bronchial epithelium responsible for paraneoplastic syndrome. Prognosis is poor for these. This is the 5-year survival rate with SCLC, I don't know what that is 7%. Yeah, I forgot what that is, but whatever. Poor prognosis. And treatment's going to be typical cancer treatments, chemotherapy with or without radiation because of metastasis. Surgery is generally not recommended due to metastasis. So you can see how, like, I think we talked about in the tumor lectures how, like, everything is, each cancer has a tropism for a different part of the body. And these are tropic a lot of times to your brain is the main one. So you can kind of monitor the brain to where that's the first place you would look for metastasis of lung cancer. So there's also non-small cell lung cancer, and you can kind of see these cells right here in this picture. Very, very large cytoplasms here, especially compared to this small cell here. So that's what we're kind of referring to, small cell and non-small cell. Now with non-small cell, there's 3 different versions: squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. So I just want y'all to know some general. What these squamous cell carcinomas, they tend to originate in the central bronchiole, while the adenocarcinoma originate in the bronchial or alveolar tissue. And the large cell carcinoma, these are polygonal cells that occur in the periphery of the lungs. So depending on where it is, you might diagnose these differently. And a lot of with the non-small cell carcinomas, you can have surgery, so that's a big difference to remove them, and radiation and chemotherapy help as well. So with these lung cancers, you have the typical stuff that you get with cancers, right? Fatigue, decreased appetite, and weight loss. And we talked about the reasons why those are all symptoms in the cancer ones. So look back at those lectures if you need to justify them. But changes in lung function as well, chronic cough, shortness of breath, wheezing, and effects of local spread and metastasis, right? Where your invasion of the mediastinum, and you have hoarseness, difficult swallowing. So what happens here is that, like, if you have some lung cancers, there's these veins that come up right here, especially ones that lead to the neck. So what some people will do, or doctors will do, is they'll get patients to like raise their hands, and if there's like a swelling of arteries in the neck, then that's indicative of cancers because it's blocking that vasculature. And that's what the superior vena cava syndrome due to compression, right? It's when you raise your hands, it compresses that whole entire area and causes a buildup of blood there. Pleural effusion, metastasis to the brain, bone, and liver. So the bone and the liver are also places that these lung cancers metastasize to. All right, and then there's also paraneoplastic syndrome. We actually mentioned this briefly in the hormone lectures, but this is hormones secreted by cancer cells. And so I think we talked about it with ADH, antidiuretic hormone. But what will happen is these cancer cells, especially small cell lung cancer, but then also in the squamous cell carcinoma, what they do is they secrete all these hormones. And then if you remember the hormone, this is like a ectopic secretion of these hormones. They're not released by the pituitary gland like they're supposed to be. And so what happens is that you release all these hormones, and then of course after you release these hormones, they're just released out into the bloodstream. They're going to act on whatever the target organ is, and so these this is where you get this paraneoplastic syndrome, where you just have different hormone regulations depending on what hormone is released from. So parathyroid, like peptide, ACTH, and ADH acting on the kidney. And we talked about the cortisol release as well. So what this leads to is just hypercalcemia, Cushing's syndrome, which we talked about in that hormone lecture, and inappropriate antidiuretic hormone secretion, right? This is ADH, which we also talked about, right? That's the vasopressin stuff, right? I think that's why I chose those two pathways, because I knew we were talking about this later. Regardless, and then yeah, I think that's it for this lecture. I'm not going to do the respiratory distress syndrome, the baby stuff, viral croup. Oh yeah, I remember all this. Yeah, so we're just going to leave that there, and we'll just to simplify it for the test for y'all. Any questions about lungs? So it's two big ones here, right? Lung cancer, know the difference between small cell and large and non-small cell, and then know all those infections, right? All right, and so let me